Hi, everybody. Welcome to, we're so happy that you could all attend. I know it's a big vacation month, but we're so happy that you took the time to come and join us for our Meet the Midwives program tonight. It's going to be about 1 hour long, and it really is to give people who know about midwives, who are choosing our service, and also for people who don't know about midwives, a little bit of an idea about what to expect from the Atrius Midwives at Newton-Wellesley Hospital. The program is going to be about 1 hour long. It is not a childbirth class, and it's structured in the way that we'll see a short video that talks briefly about midwives. We will introduce all of us midwives that are here tonight, and then we'll answer the top 4 most frequently asked questions that we get repeatedly at every Meet the Midwives. And then we are going to open it up to your questions. So a couple of things to know about getting your question answered. Please use the Q&A and not the chat. The Q&A is the place where we're searching out your questions. We want to be able to answer and get you the information. So Q&A, folks. With that being said, I think we'll launch right into the video.
Midwifery?
Midwifery.
Is that right? Midwifery?
I don't know.
Midwifery.
Midwifery, yes.
Is that like a female in her 30s, like, I don't know, married woman?
I know they help during the birth of a child, but that's pretty much all that I know about it.
A midwife can also, as I know, like provide some pain relief in terms of like breathing exercises and things like that.
I think midwives work at a hospital.
Some are in hospitals, some are at home.
I don't think they work in a hospital.
Midwives are everywhere. We're in the home, offices, giving prenatal care, giving family planning care. We work in hospitals, we work in birth centers.
Most people, when you think of a midwife, you just think of somebody who helps women have babies. But we do a lot more than that. We work with women throughout their life cycle.
When someone comes to see a midwife, they often wonder about what we can do for them as far as pain management, as far as medications. They're worried that if you're with a midwife, you can't have an epidural, for example, which is not true. I think a lot of people are surprised to hear the level of training and education that is required to be a midwife in the U.S. because midwives do so much more than just birth.
We provide personalized care.
The main reason I chose a midwife is because I wasn't a number. I was actually a patient, I was actually a person with feelings, and they were gonna devote the time that I needed to answer all of my questions, address my concerns. They want you to make, good choices for you and your unborn baby. I'm so glad that I chose a midwife. It's definitely an ongoing relationship.
Midwives have reduced the cesarean section rate in this country. It's overall been drifting up in the range of 30%. The midwife practice here at GW has a cesarean section delivery rate of 5%. Physicians plus midwives is a way of putting together the collaboration that responds to what the patients want. Doctors should advocate for the midwives. I enjoy the sharing, I enjoy the collaboration.
I chose a midwife because they are trained to deal with birth as a normal process, not a medical emergency. I plan to use a midwife for the rest of my life for my healthcare needs. I trust them and know that they have my best interests in mind, and that's really important to me.
As midwives, our philosophy of care is based on respect for women.
We put the woman and her family at the center of the care and then build out from that.
We collaborate together. We're partners.
I think all women deserve a midwife.
Every woman deserves high quality, evidence-based, personalized care, and we're here to make it happen.
All right, I hope you all got a little bit out of that. We're going to move right into introductions of the midwives that are here. And Kate Murphy is going to talk to us first. Kate.
Hi, my name is Kate Murphy. I am one of the midwives. I'm mainly in Norwood and also at the hospital. And I have 3 kids and I'm busy and love being part of our group.
Great. Where's Megan?
Right here. Hi, I'm Megan. I work out of the Wellesley office and also at the hospital. I'm relatively new midwife to the group, but I'm very excited to be here.
Do you have a fun fact, Megan?
Oh, sure. So my fun fact for tonight is I once attended a silent disco in Washington, D.C. We all had headphones and were listening to the same track and had a big dance party on the National Mall.
Wow, that's pretty great. I'm Carol Hong. I'm one of the midwives that practice in the Wellesley office. My pronouns are she and her. I also deliver babies at Newton-Wellesley Hospital. And my fun fact is that I am a long-time reluctant chicken farmer. I have chickens that lay blue eggs, and we have 2 roosters who are, well, I don't want to use foul language, but they're a pain. And they're called Jared and Derek. We yell at them all the time. Molly, you're next.
Thanks, Carol. Hi, guys. I am Molly Doyle, pronouns she and her. I am at the West Roxbury Chestnut Hill location, also at Newton-Wellesley catching babies. And my fun fact is that after college, I went and lived abroad in Germany, and I was an au pair for 6 months, and I got to go to Oktoberfest in Munich, which was really cool to experience Oktoberfest actually in Germany. So, Prost.
That's great. Deb is next.
Hi, my name is Deb Cordero Fiedler. I am a hospitalist, which means that rather splitting my time between the office and the hospital, I am at the hospital exclusively, which I love doing. I had a fun fact that I've just changed because Carol and Jill both have chickens. And I have a little chicken story. And when I was young, we used to get little peeps for Easter, and you could buy them. And I got a blue one, my sister got a pink one, and mine grew up to be an adult and I guess bonded with me and printed and would follow me all around, take them on walks in the neighborhood. So even though you 2 have chickens and actually get eggs, I do have a chicken story.
Thanks, Deb. Mary Kay, you get to go next.
Hi, everyone. Welcome. My name is Mary Gosney. My pronouns are she and her. I practice at the Norwood office and also at Newton-Wellesley. My fun facts always involve my grandsons, and I just had a beautiful trip to Niagara Falls with a 2.5, a 4.5-year-old, and a 5-month-old baby. Just picture the drive from Boston to Niagara, and we survived. We had so much fun, and we all went on Maid of the Mist, and it was awesome. So that's my fun fact.
Mary Kay. That's your saintly fun fact.
Yes.
Okay. Jill Sandine, Jolly Jill, you're next.
Hi, my name is Jill, and I also do all my work at Newton-Wellesley Hospital. I'm not anymore in the office, although I was for many, many years. And in addition to having chickens, as Deb revealed, my fun fact is that I just got a diary that my mom wrote starting January of 1958. I was born in May of 1958 in Cambridge, England. And I've had a lot of fun reading what she wrote every day of the year, including the day of my birth in May. And it's been really fun to read about it.
That's great. That's fantastic, Jill. Maybe you'll publish it one day. So the next thing we're going to do is we're going to answer the most frequently asked questions that we get at all of the Meet the Midwives. And Kate is going to start. And Kate has agreed to give us her fun fact to kick off the questions since she didn't get the chance. So go ahead, Kate. The first question for you is, what's the difference between a midwife and an OB in terms of the care, and what does it look like at Newton-Wellesley Hospital? And your fun fact.
Okay, sorry, forgot to share my fun fact. I don't have chickens. I'm not getting chickens. I have 3 boys and they want a dog very badly. My middle one especially, he has given my phone number to multiple websites, and I'm getting frequent calls from puppyspot.com and text messages, and it's named. So I'm getting persuaded, but it's not happening until at least next spring, but we'll see. So we'll start there with our pets. So the differences between a physician and a midwife, you may recognize some of these things just from your care in our office. Most of you probably see a physician and a midwife, or perhaps a nurse practitioner, or maybe 2 of us, and you might notice some of the differences. Our training is a big difference. Our physicians go to medical school and complete a residency and have extensive training in obstetrics and surgeries and higher risk pregnancies and a lot of medical complications. As midwives, we all were initially nurses and then went back and got a master's degree in midwifery and are trained really to focus and to specialize on normal, healthy pregnancies, well women care, and lots of other gynecologic things. But in regards to pregnancy, we really try to focus not only on the medical aspect of your pregnancy, but also on emotional and mental aspects of your pregnancy, talking to things about how it's going to change your family and what you're doing to prepare during your pregnancy and prepare for your labor and your birth experience. At the hospital, and so we really try to focus on the lower risk aspects and let our physicians focus on the higher risk things. But because we do work in a collaborative practice and we do have advanced training, if there are minor medical things going on with your pregnancy, we're well skilled to care for those things and to recognize them and to deal with those in your pregnancy. Same thing at the hospital. We do a lot of the vaginal births for our practice. At the hospital, our physicians work as our backup. We work very closely together at the hospital, and we have a lot more time to spend with you, usually at the hospital, on the normal things of your labor and your birth, providing labor support, being more present during your birth experience, because we don't have those other obligations that they do have at the hospital. Those are kind of very summing it up quickly. Feel free to ask more questions and to talk about it.
Thanks so much, Kate. The next question is going to be for Megan, and the question is, how do the midwives and doctors work collaboratively during a labor? So Megan will answer that question for us if she doesn't mind.
Sure. So Kate touched briefly a little bit on this just at the end of what she was discussing, but we work very closely in the hospital throughout labor and birth. So we always have one of our midwives and one of our physicians on staff. And I'm sorry, my dog is right here. She came up during this discussion. But we have one of our midwives and one of our doctors always at the hospital. And in the mornings, we always have a formal report. So we talk with our whole team about all of the patients that are on the floor. So we're all aware of what's going on. And then throughout the day, we have kind of informal conversations to update our colleagues about what's going on. So You might just see a midwife during the whole time that you're at the hospital, but if anything comes up during your stay that we need to refer to the physicians, we have them right there with us and they'll be able to come in the room. So you have a whole team who's making a plan together, making sure that we're on the same page about the safest way to care for you, and being able to meet you if you need that additional level of care beyond midwifery.
Great, thank you so much, Megan. Question number 3, I'll go ahead and answer. And it is, who is going to, okay. Question number 3 is actually, who's going to be in the room with me when I give birth? And the answer is now, during COVID, which is still happening, I guess, you can have your doula, you can have your support person, in addition to whoever your significant or primary support person is going to be. And then there will be your midwife, your dedicated labor nurse, and then a nurse that is specifically there just to care for the baby. That nurse will often give us a helping hand to the delivery nurse once the baby is born. We try really to have as few people there as possible so the experience can remain personal and intimate and quiet for you. So that's the short and concise answer. The next question is going to be for Molly. And that question is, how is my midwife going to help me during labor with the pain that I may experience?
Yeah, thank you, Carol. I think the most important one with a midwife is that we're going to listen, and we're going to listen to you and your partner and what your ideas were for birth. So just having really good listening ears is helpful. Starting in the prenatal visits, we're going to encourage childbirth education classes, looking into doula support if that's something that is beneficial to you and to your partner and to your family as a whole. So we're going to encourage those things from the beginning, start the conversation early. And then once we're actually in labor, right, letting you know what's going on, making sure that we're doing the appropriate monitoring so we can be as hands-off as safely possible, encouraging position changes, working with your nurse, because we're all a team there together to support you guys and to have a nice, healthy baby and satisfactory birth experience as well, too. We can talk about different pain management options. We can talk about non-pharmacological options, such as heat or hydrotherapy, getting in the tub, massage. And then if you decide on an epidural and that's your choice, we support you in that as well too. So offering medication if necessary, but also alternatives to kind of keep you moving and upright. And then most importantly, just keeping you involved the whole process so you know what's going on and you understand, and there's informed consent and shared decision making the entire time. So we're there to answer your questions and to be your resource and also your biggest cheerleader or your tough love, whatever you need at the moment. We are very versatile, wear many hats, but we are there to support you in whatever you're feeling with your labor course.
Great, thank you so much, Molly. The next question, or actually the statistics of our practice, specifically our Atrius practice. Deb is going to go over some of the ones that we often get asked about.
So just to start out, because we're in a collaborative practice, the way we collect statistics is we look at the women that we care for in labor. As has already been said, when you enter the hospital in labor, usually you have already decided, do you want your primary provider to be a midwife or a physician? So the statistics that we are going to see tonight are the people who came to us, we admitted in labor and cared for in labor, and this shows the outcome of our management of labor. So in 2021, we had a total of 810 births in our practice, and we do slightly more of the births than our physician colleagues. 80% of the women under our care opt for epidurals, and this can sometimes people look at that and think, well, if I, come to your practice, does that mean I'm going to get an epidural? We, as Molly said, we listen to you, and a lot of people come in with the plan to have an epidural, but we also provide support for those who would prefer to avoid one. 24% of our labors are induced, and for the most part, we have some that are for post dates, meaning I guess late term, and then we have some medically indicated inductions as well. 2% of the people we care for get an episiotomy, and the 268 years of combined midwifery experience is always moving slightly as someone retires, somebody joins our practice, but many, many years of experience we bring to your care. So in 2021, our primary cesarean birth rate was 9%. And in 2020, the national rate, which is not just primary cesareans, but also repeat ones, is 31.7. So you can see that our rate is very low. And for those, as I said, we're looking at our primary cesarean rate for those who are have a cesarean that comes out of labor, but we also have some women who have a repeat cesarean, and those are the women that come to us who have had at least one other cesarean and are opting to have a vaginal birth after cesarean, that's VBAC. And 70% of the women who we've cared for who had a previous C-section had a VBAC. So they achieved that. And if you look at other practices, other hospitals, it's a very good rate. So 70% have a vaginal birth after cesarean. And that's it.
Great, thanks so much. Thanks so much, Deb. The next question is for Mary Kay, and it is, I'm going to summarize here. Is there an option for a pregnant person to have the option of delivering at Mount Auburn or another birth center? Mary Kay?
Thank you, Carol. Thanks for that great question. We currently do have that option. Our midwifery practice is at Newton-Wellesley, and we also have a collaborating practice with the Mount Auburn Midwives. So any patient that comes into our practice seeking midwifery care can either have their birth with us at Newton-Wellesley or can opt for a birth with the Mount Auburn Midwives. We have, as of July 1st, started an independent midwifery practice at the Cambridge Atrius Health office. Myself, Jessica Elmeyer, and Lucia Ma are the midwives that will be working and practicing at that Atrius Cambridge site. Jessica is also going to be practicing at Watertown, and patients can go to any Atrius office and have the option of having a midwife. We do recommend, if you're thinking of the Bain Birthing Center, to make that choice by about 28 weeks so we can collaborate and coordinate your care accordingly. So thank you for that question. If anybody has any specific questions, you could always email me directly. I believe you got an email registration for Meet the Midwives from me, so you can just email me and ask your question directly. Thanks.
Great, thank you so much, Mary Kay. Jill, if you wouldn't mind answering the question, do the midwives work with patients who hope to have VBAC?
Yes, so Deb's statistics touched on this in terms of our help having women have a successful VBAC. I wanted to tag on to one thing that Mary Kay said, and that is seems weird, but you should check your insurance to see what hospital is allowed. It seems counterintuitive that if you come to us that you can't come to the hospital that we deliver at, but in rare circumstances that's the case. So I would say yes, in general you can choose where you want to go, Mount Auburn or Newton-Wellesley, but I would double check your insurance. Anyway, back to the question that's assigned to me. So the work that we do to help women have a successful vaginal birth after cesarean starts at the very beginning of the pregnancy. And this is key because women have primary C-sections for a whole variety of reasons. And it's our job as your office providers to sort of talk through what happened the first time and what might have been some of the issues, and help you make an informed decision about going for a vaginal birth after cesarean. Most cases, it's a completely reasonable and positive thing to do. There are some risks which we will talk to you about and explain and explore with you. And the woman, the birthing person and her partner need to sort of discuss those risks. And then we, as somebody mentioned, I think Kate, about childbirth classes. If you didn't take childbirth classes the first time, we would encourage you to do that again. And there are classes specifically for women who've had a prior cesarean. So we'd encourage you to do that because in many cases, having a successful vaginal birth, there's this point in the first pregnancy where something got stuck or something happened, and that has an emotional component that I think we're well equipped to sort of work through with you as your pregnancy proceeds. I would say this, that there is never a more triumphant birth to attend than a successful VBAC. It's so empowering for people to have that vaginal birth after cesarean, but sometimes it doesn't work. And we're there to help you navigate all the feelings that involves as well.
Great. Thank you for that answer, Jill. We appreciate that. Kate, you're up next to answer the question. In what scenarios, how about the most common scenarios or conditions would warrant the OB to get involved or completely take over the care of a person in labor? And can you still work with a midwife if you're also seeing a maternal fetal medicine person?
Okay, thanks, Carol. So essentially there's a number of reasons, and not to get too nuanced at all, that an OB may completely take over your care. These are things that you're going to know about most of the time, very early in the pregnancy. And it's usually women who might have some conditions that they had even before getting pregnant that are really, really, really best suited, and you really deserve the care of a physician for that. And that may be the best provider for you. Those women will know that very early. There's a lot of people who may see both of us. And then in the hospital, if you need a physician to completely take over your care, you may, usually we have some clues to that. So the most common reason is you need your baby to be delivered surgically, which would be a C-section, or sometimes with what we call an assisted vaginal birth, which would be something like forceps or a vacuum more commonly. Those are things that our physicians do and we do not. So those are complete transitions of care. Sometimes we're really worried about something that may be going on with you, maybe your blood pressure or perhaps your baby. There's a lot of things that fall in the middle where we kind of collaborate together, which is a really nice aspect of our practice, that we can share your care and kind of work together as a team. As far as maternal fetal medicine, which is the MFM, there are many, many women that we care for who see maternal fetal medicine throughout their pregnancy, who still have beautiful midwifery births. And again, these are things that in the office, if for some reason you're seeing maternal fetal medicine and they recommend a physician, you will likely know about that and have a lot of time to talk about that during your pregnancy. And it shouldn't really be a surprise to you when you come to the hospital. But certainly we are well able to collaborate with them to care for you.
Great. Thanks so much, Kate. The next question, Megan, if you wouldn't mind answering it, is how do we include partners and doulas during labor care?
Sure. So we love working with partners and doulas during labor. I think it goes back a little bit to what Molly was talking about with the coping strategies and really listening to you and what you need during labor. Some people really feel most comfortable with their partner providing most of the support during labor and kind of like physical coping support during labor. Some people feel more comfortable with their doula doing that. And then as midwives, we also can provide that support. So we work with a lot of partners to kind of teach massage and other things they can do like counter pressure during labor to help support you and help you cope with the pain of labor. Brainstorming with doulas about different positions that might be helpful. Doulas have so much experience with, different position changes and other coping strategies, and we can work together to assess how your labor is progressing and what's going on with your baby and brainstorm kind of different things that might help with progressing your labor and making you feel more comfortable. So we always love to make sure we're listening to what you want and how you want people to be involved in your labor, and that we are fully explaining what's going on so that we can keep partners and doulas involved in your care the whole time.
Exactly. Thanks so much, Megan. The next question is, I was told that forgive me. The question is, will I have to choose basically between a midwife and a physician at some point during the pregnancy? And do we have to choose one over the other? And the answer to the question is yes, you do. You can choose a midwife or you can choose a doctor. We're not both going to be attending your birth in the most typical situations. There's a few situations that might be the case. As Kate alluded to, if you needed a vacuum delivery and you were having free care, it's the physician that will help your baby be born with a vacuum. And the midwife doesn't leave the room and say, I'm all done now. We stay there and support you. But yes, you do need to choose one over the other. And that is simply because, we try really hard to give everyone as much attention as we can. And generally speaking, we have a little bit more, the midwives do have a little bit more time to spend with our laboring patients because our focus is on labor and delivery. So if you're somebody who's chosen midwifery care, we want to be able to give you the benefit of that. And if we had a doctor and a midwife with every birth, I think there'd be a lot less time for us to spend with those people who truly had chosen midwifery care. So I hope that answers your question. The next question is going to be for Molly, and it is, what are my rights as a patient to consent or to not consent to interventions that are suggested in the hospital?
Yeah, that's a great question. So as midwives, we believe that no one should be ever doing anything to you or to your baby without your consent. But that also goes back to choosing a care team that you trust. And so through the prenatal course, you guys are having conversations together, you're trusting our judgment, we're relying on your input and your feelings towards things, but there should be a healthy respect for our role as your midwife. And so that role is to provide a safe passage for your baby into this earthside world. And with that being said, we are there to watch the monitors and look for concerning signs. And we want to support you and be warm and fuzzy as possible. But there are things that can deviate from a normal track. And that is our job to make sure we're still staying on a safe course. And so I'd hope that the trust that we built over the previous 9 months would allow you to be for us to say, okay, so, Carol, this is what's kind of changed in the labor course, or this would be our suggestion or recommendation, and this is why we would recommend, or this is why we think this intervention would be helpful. And so, you always have the right to decline something, but hopefully because of that trust that we have, we're not there to harm you or your baby. And so you're taking what we're saying and, a lot of time to process and then really trusting our judgment with that. So it's a shared decision conversation, even in an emergency, hopefully there's some conversations still happening and it can seem really chaotic in the time, but as midwives, I think we do a really really good job of communicating with you and your partner about why things have changed and what this next step may mean. So you should be asking questions if something seems confusing to you, and we're happy to explain everything. Obviously, we love to talk and teach. That's why we're here. But it should never feel like something's being done or you don't know what's happening to your body or your baby. So feel free to ask, and we advocate for you. And this is where the role of like a doula can be really helpful too, because things can just be a different world, if you don't work in the medical setting. And so having someone that can kind of translate that for you as well can be really helpful. I hope that answers your question.
Thanks, Molly. That was a good answer. If Deb could answer the question, what are the odds that the midwife that I have worked with throughout my pregnancy will actually be the provider that I work with during my delivery? Don't forget to unmute.
I would say it's very fun to arrive at the hospital in labor, and there's your midwife from the office, and that's really special. But I would say for the most part, it will not be your office provider. And if it's me, I don't work at any offices, so I am completely meeting people fresh. I would have to say that in the office, when you're interacting with your office provider, you're in your head, okay? You're talking, gathering information, asking questions, all of that. When you're in labor, you're in your body, okay? So you are really, when you're in active labor, you're kind of go what we call labor land. And so, yes, you are hearing and, having a conversation, but you're laboring. And I think we're all united by the midwifery philosophy. And I think that, we all have different personalities. We bring different things to your birth, but we often think that, the person who's there with you and in the moment will be working with you and give you what you need. And then when the birth is all over, you can go to the office and hopefully bring your baby, and your office provider will be able to enjoy. So.
Thanks so much, Deb. So Mary Kay, can you answer the question, where can one get the schedule of who is on call at any given time at Newton-Wellesley?
Sure, I'd love to give that answer. The schedule is done about 6 months ahead. It's a computerized schedule, and it is a practice-only document. So I always, encourage patients to talk to their providers at the office. When I see my patients, they know that I'm not on call as much because I'm the practice director, but sometimes I can just appear. If people get sick, we have schedule changes. If people have family things come up, we have schedule changes. So even the schedule that we do months ahead can often change. And to just, add to Deb's previous answer, the thing that I love about being a midwife is that when I meet a woman and her family for the first time, there's immediate connection. And you don't understand it until it occurs and happens to you. And I know there's just a few of us on this call because some of our colleagues that you might have met in the office are on vacation and they're unable to be here. But that birth plan and that conversation and all your hopes and dreams that you've had these conversations about during your care in those prenatal visits, we will honor and respect and care for you lovingly when you come into labor. And that's the best way that I could explain our call schedule, and where we publish it. Even the hospital has, when I walk in, they'll say, Molly was on. Where's Molly? It's like, sorry, guys, it's me, and everybody meets me that night or that day. So that's how our schedules work.
Thanks so much, Mary Kay. If Jill, would you mind answering the questions? There's been a few questions actually about this in particular. And the question is about selecting a midwife if they're with another practice. How does one get a midwife if you're with another practice?
So if you're with another practice that doesn't have midwives, which I'm assuming is the question, then in order to have one of us or some of our colleagues who, as Mary Kay said, were on vacation, attend your birth and provide you care at Newton-Wellesley Hospital, then you actually have to transfer your care to one of our Atrius offices. We have many of them. And it seems like a big deal, but it actually isn't such a big deal. We would ideally like to see people transfer as early in the pregnancy as they can, but we will take people up to about 36, 37 weeks, as long as their pregnancies aren't super complicated. But yeah, I mean, in order to have a midwife attend your birth, if you're going to a practice that has no midwives, then you need to transfer out of that practice and go to a practice like ours that does. Records can be transferred easily. You make an appointment just like you would at any office, call and say, I've been seen up to 15 weeks or 24 weeks at such and such, and I'd like to transfer to your practice. And I think on the Atrius website, you can see all the various offices, but some of them are Wellesley, Norwood, Dedham, West Roxbury or Chestnut Hill, now Cambridge, Watertown, and so forth. So any of those places, you will see some of us, right? And then you will establish a relationship with one of the midwives who works out of that office. But as the previous panelists have said, you may not see that person in labor because we rotate call. And one more thing I would add to that Deb and Mary Kay have said is that the idea that the particular midwife you've been seeing in the office is key to your good birth experience is actually kind of a false notion, because that puts a lot of emphasis on the midwife, and really the emphasis is on you. And all of us are well prepared to help bring out from you what you need to birth your baby. So it's less important to recognize the face than you think it would be, is what I would say.
Great, that's a really excellent point, Jill. That's an excellent point. Thank you so much for that. The next person who's up is Kate, and the question it's more of a it's not really a question, I guess. Kate, if you wouldn't mind talking a bit about the shared decision making, or how decisions are made when an intervention is recommended, something like an episiotomy or an induction of labor, or maybe an operative delivery. How do those decisions get made?
Okay, so that's a sort of a vague question. So a general answer is, one of the sort of hallmarks of our practice that we all value is something called shared decision making, which means, and also informed consent, which are a little bit different, but on the same level, is that you're really an active partner in your care, which means we're providing you all the information, all the medical risks, all the benefits to you of whatever intervention we are perhaps discussing. So maybe that's induction, maybe that's an episiotomy, maybe that's an assisted vaginal delivery, or just things during your pregnancy even as well. And because we want you to really understand and also be in agreement with things that are happening to you when you're in a somewhat vulnerable situation, as labor and delivery can certainly feel like. So in general, these are the reasons we would give you. Sometimes we might say, these are all very reasonable options in this situation. What do you think you want to start with? What seems right for you? What can we do to work together? And sometimes we might say, you do have a few options, but I think this might be the safest one, or I think this might be what I would recommend for you. And all of these things are just unique to the situation that we're talking about. But it is very important to us that you feel heard and you feel understood, and that you feel that you are making an active decision in your care. And kind of like Molly said during one of her answers, sometimes these things do happen quickly. And sometimes we are having conversations that are fast. That's never our goal. And we need to make a decision. And sometimes we don't have a lot of time to wait or to really go back and forth, but that is the exception and not the common thing. And even in those situations, we try really, really hard to support you and your partner and whoever else may be with you, and to talk to you and to make sure you know what's going on. Because it can be an overwhelming and it's an unfamiliar scenario. And sometimes you've never even been in a hospital. And we want to make you feel as comfortable and as well supported in your experience, for sure.
Great. Thanks so much, Kate. Megan, it's your turn to answer the question. Do I need to get my birth plan to the hospital before labor, or can I bring it with me once labor started?
Yeah, so you can definitely bring your birth plan with you to the hospital once labor is started. It's always helpful to have a few copies so you can make sure that the nursing team has a copy and the midwives have a copy, and we're kind of all on the same page about your birth preferences. But I think it's also really important to talk about your birth preferences during your prenatal care, so you can go over different choices that might be available to you, different interventions that might come up, and how you might think about what you want your approach to those interventions to be. And you can talk about all those things with your providers in the office, and we make lots of notes in your chart about what your birth preferences are, especially if you have a really strong, preference for a certain thing. We can make sure that's in your chart so that when you arrive at the hospital, whoever is on call that day, as we've all said, whoever's on call that day can look at what your birth preferences are and kind of have an idea of that. So when they go in to meet you, you can share your birth plan with them, but they'll already have an idea from those conversations that you've had during your prenatal care about what your preferences are. So we absolutely want to support you in whatever way we can with your birthing plan, but having those conversations early on is best.
Great. Thanks so much, Megan. I appreciate that. The next question I'll answer, and it is, do you do routine gynecological care? Hoping to get pregnant again soon and would like to establish care. Make an appointment. We do GYN care, we do birth control care, we do pap smears, we do prenatal care, we do postpartum care, we do lactation care, and sometimes, sometimes we do other things, which is really part of your care. We continue to offer you support as you journey through motherhood, as you journey through motherhood with a toddler, with a teenager, and even an adult child. I know myself, I have seen some of my patients semi-grown up adult children for their first GYN care. So yes, the answer to your question is yes, we do. Midwives will provide gynecologic care to you throughout your lifespan. I hope that answered the question. The next question is going to be for Molly, and it is, am I going to be able to labor in a position that's most comfortable for me, or is it encouraged for me to strictly labor laying on my back?
Oh my gosh, yes. Whatever you want is really how it goes. Even with an epidural, we use peanut balls, different positioning tools to really get you in all the different positions. And if we put you in a certain way and you're not comfortable, then you just tell us and we change it. We've got a whole book of things that we can try and do. We try all the things, and some patients really do prefer like pushing on their back. They feel more powerful. Great. But we're going to give you feedback as your midwife saying, yep, I see some fetal descent. Let's try this instead. So we'll do whatever you would like. You want to sit on your head, great. We'll catch babies however they want to come, but we just want to keep you as safe as possible, so maybe not on your head. But yes, all is fair game, and whatever you feel comfortable and powerful with.
Great, thanks, Molly. We hope that you do move around in labor and that you aren't on your back. Deb, if you could answer the question, how long is a midwife's shift at the hospital? Including, a midwife that might be seeing women after they've given birth. I think you're muted, Deb.
Okay. Our call shifts are and the rounding shift is from 8 to For the most part, there's one midwife who's on call covering the labor and delivery unit. And then a midwife comes in from 8 a.m. to 2 p.m. to see all the postpartum patients. Occasionally on the day shift, the rounder can help the midwife on call, or the midwife on call could help the rounder. But then once the rounder leaves, you have the day call with the shifts changing then again at 8 p.m. And one more thing too is between the changes, we talk between the midwife who had been on, the midwife coming on, and really give an update so that we have an idea of what was going on when we arrive.
Thanks, Deb. Mary Kay, your question is, will the practice or our midwife remind us to complete the pre-registration forms and submit them on our behalf to Newton-Wellesley Hospital? Or do we need to complete them and mail them in on our own?
So at the Norwood practice, between 26 and 30 weeks, in most of the offices, you have a registration packet for the hospital that you're planning to birth at. And there's the OB care consent we'll review with you. There's registration. There's a nursing form, a birth plan. There's also a healthcare proxy and information on the front of the packet as to how to, make copies, who to send what to. There's envelopes in that packet. And if for some reason you don't get the packet by 30 weeks, please let your office know and your care provider who you're seeing. Because I know some of the offices have scaled down on the paper, like Wellesley. When I go over to Wellesley, I'm like lost because I don't have all that paperwork that I usually give my patients at Norwood and Dedham. Just, check in with your care provider and we'll make sure that you get all those forms.
All right, thank you so much, Mary Kay. The last question that we have time for this session here is going to be for Jill. And the question is it the norm at the hospital to have external fetal monitoring? Is it continuous or intermittent? And do we need to specifically request that? I think that's what the question is.
Yeah, I read the question and I was a little bit confused. So I'll try to answer it in a way that covers all bases. I think the question is kind of how do we monitor how the baby is doing? And I have this conversation with most of the women I'm with, but we have machines that are external fetal monitors, and they're identical in terms of technology to what your midwife is using in the office, which is a simple little Doptone, a little microphone with a little transducer, except that at the hospital, it goes, the information goes and it gets written down. And whether a woman is continuously monitored in labor or intermittently monitored with this bigger machine has to do with what's going on in her labor and what other things are going on. There are certain situations where continuous monitoring is essential. For example, if Pitocin is being used, we want to make sure that we're not giving too much Pitocin. So we need to monitor A, how the baby is doing, but also B, how many contractions she's getting. So we're very careful to not give too much, and that requires continuous monitoring. Another case would be if a woman chooses to have an epidural, then she is also continuously monitored. Not that the epidural goes directly to the baby, but it's part of the policy at the hospital to have continuous monitoring in those cases. If the baby sounds, when you come in labor, we always do an initial monitor strip, and that is just to prove to everyone, you and us, that your baby looks good when you get to the hospital. And then in the cases of intermittent monitoring, there are criteria for how frequently we need to monitor depending on where you are in labor. So if you're in very early labor, of course, we'd it's better to be at home, but if you end up at the hospital when you're in very early labor, we don't need to listen that often because the labor is not so intense that we need to know every second of what's going on. But when you're pushing, we need to listen more frequently. Does it need to be continuous at that point when all other things that require continuous monitoring are not happening? No, we can listen intermittently at that point. One thing that's kind of dovetailing off of this is the conversation I have with lots of my patients. Listening to the baby's heartbeat is the only way we have to know how a baby is doing. And it's a completely imperfect way to know. It's very good at telling us that things look good, but it's not as good telling us things definitely don't look good. So over the many years that I have practiced, we've tried other things to kind of fine tune what the fetal monitor is telling us, and none of them have worked. So we're stuck with the baby's heartbeat. And you will notice when you're in labor that sometimes we hear things that we have to respond to because that's all we have to know how your baby is doing. But it doesn't necessarily mean anything bad is happening. It's just that we're hearing something that we need to maybe change your position, et cetera, to make sure your baby sounds good, right? So I hope that's the question that was answered. I would say statistically, many women have continuous monitoring, but that's because of choices they've made in their labor process, and also how the labor unfolds requires via our policy to do continuous monitoring, but it's not essential. I hope that's what the question was.
I hope so too. Thanks, Jill. The last question, we have to squeeze one more in here because I think it's an important question and I'll answer it quickly. It's how many patients does a midwife on call have at one time? So we do have guidelines and standards about how many women we can safely care for at one time, and that is 3 actively laboring women. So our doctors also have the same guidelines, and we practice very similarly in terms of looking at what is safest for you and your baby. Whereas if we have women that are not actively in labor, the numbers are a little bit different. So the answer to the question, the short answer to the question is 3 patients at one time who are actively laboring. Of course, if we feel like we need help because one person has a particularly complicated labor course or whatever the case is, then we do have a means to ask our colleagues, our OB colleagues, and sometimes our midwifery colleagues that might be in the hospital still doing rounds or whatever the case is to give us a hand. So that's the short answer. That's all we have time for. So I want to just take a quick minute to say that if you did not get the information that you wanted, you still have a remaining question, make an appointment with the midwife or email us. We're all responsive to email, and we want to make sure that you have the information that you need, to make the right decisions for you and your family in labor and also antenatally during your prenatal care. So please email us any questions that you didn't get answered that you would like answered. And I also want to give Sherry a chance to come on to the screen here and talk for 2 minutes about a couple of other things at Newton-Wellesley Hospital that might make your experience there a bit better. Sherry.
Thank you so much. I'm so glad to be here. It's so fun listening to you and all of your fun facts and all these amazing questions. I'm the one behind the scenes sending your questions to the right people. So thank you so much for letting me be a part of it and part of your preparation overall, because I'm here to talk for just 2 seconds about our childbirth education department and the virtual tour. Some of you guys asked questions that are really helpful and answered on the tour. We go into deep detail on tubs and showers and COVID testing and where, can my partner sleep and all of those things. We answer that. So that is a free session. It is so much fun to teach, actually. And so I invite you to that. I'm going to throw that down in the chat. so that you have the link nice and easy for any childbirth education needs that you might have. I also included my email in a couple of places to some of your chat things if I can be helpful in any of those areas. But thank you, and I'm so glad that you chose to work with this group of midwives because you guys are in awesome hands. Thanks again.
Thank you so much. Bye, everybody.